Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
Hello, Lesley. We are without Jo again today. She's on vacation. I think she's been visiting grandkids again. So you and I have been teaching a lot in some of these hospitals and rehab hospitals around here about what we've now come to call hospital-acquired frailty, because I hate the term cascaded dependency. Right. And so the reason we call it hospital-acquired frailty is because it seems to shine a brighter spotlight on the actual issue. And anything that's hospital-acquired, anything seems to get a lot more traction and attention. And because we see these things, downstream from us, or for us, at the home health level, we see kind of what happens if we don't prevent these things from happening at the facility level. And so we've been teaching like all these details and these stats and all these things, with a lot of these rehab departments and hospitals. And we've brought up some of this stuff on the show, but now we're starting to go back through and teach, okay, now how do we actually prevent it? And so what's really interesting, and I know you've got some connections off this too, when I did this post a few months ago with my own grandmother, and there was like this before and after, which I think was probably the most powerful part of it. I mean, the story itself it's sad and it's impactful, but I think when you see like a before, like 2 weeks ago, and then now, right, nobody gets to see that. And so when we typically get to see them at the hospital level, the bad things already happened. They've had a few days where this decline is already starting. Mm-hmm. And so when we walk in as a nurse or as a therapist, we're like, okay, yeah, she's 85 years old. Right. She's weak, she's frail. This is she
fits the story.
Yeah. Yeah. And so, but it wasn't until people saw, holy smokes, this is very different when you see somebody 2 weeks ago looking there's a stark contrast to what ends up happening within just a couple days and in a couple weeks in a hospital. And so because I posted that, there was all these, it was amazing, nurses, therapists, doctors from like all over the world, mm-hmm. Australia, China, Japan, Africa. I've had a couple of them from Middle East. And fortunately, they all speak English, which is helpful when you communicate via DMs. Because I don't speak any of that stuff. But anyway, so they shared stories. And so some of them were like public comments and other ones were like private DMs to me. And so they shared stories and things that they have personally seen or experienced with their own family members. And in some cases, they shared with me, hey, here's a couple of things that we found to be successful at our hospital. And I was like, oh my gosh, this is like the best thing ever. Because you can go study for some of these things, but some of these things, people are, I don't want to say we're tinkerers, but people are trying stuff out, like in smaller sample sizes that aren't necessarily out there in the public forum, like to kind of observe
acceptable norms.
Yeah. And so so I learned a ton, and there was like an ICU lady I know you're going to talk about in a few minutes that has it's been really cool. One, the collaboration across all these disciplines and across all these countries. I got connected with the head guy at Johns Hopkins for their ambulatory mobility program. So I've learned a lot from what they're doing, and some other, like there's a local hospital in Louisiana that's doing some really cool stuff. And so I figured, in the absence of Jo, since you and I have been teaching this everywhere, it seems like lately, that would be a good idea for the podcast to actually go through, okay, now that we know like all the bad stuff that happens because of immobility, we'll go through a few, like a summary points here. What are some key things that we can do to help prevent it? What have some other hospitals figured out, or rehab hospitals figured out that can help with this stuff? So as a quick review, remember when it comes to, again, if you want to look this up on your own, you have to look up the term cascade dependency, because hospital-acquired frailty isn't the accepted one yet, and we're going to make that happen.
That's right.
But cascaded dependency, what you'll find is it is a multi-system decline. And it's not like a cascade normally happens where it's like one domino, then the next, and the next. This is like all these dominoes all at once happening together. But they also have a feedback loop on each other. And so it's all these systems. It's cognition, it's urinary system, it's pulmonary system, it's cardiovascular system. It's obviously your muscle system, right? Because we typically see that as like if we stop moving, we're going to get weaker. Like that's an obvious one to see. What's not so obvious is your immune system can actually be impacted negatively by this, right? And so figure out, we would go through a few quick stats just to kind of set everybody in as a summary of last time. So they say upwards of 70% of elderly patients that go through a hospital will develop a pressure ulcer within their first 2 weeks. 70%. That just goes to show you we're not
much.
Yeah, it's not
and that's with preventative measures probably in place too, like
correct.
Moving patients with some mobilization. It's just much. It happens so fast.
It's the immobility part. It's also not a focus on offloading. I mean, there's so many things that go into the nutritional side of things, which is a whole other series of conversations we can have about the nutritional impact of hospitals. Also, by the way, when you go in for a sepsis event, like I did a couple years ago, and the first things on your breakfast menu are pancakes and waffles, that's probably the wrong approach for the hospital. But be that as it may. So pressure ulcers we see, they see upwards of 50 times the bone reabsorption for someone who's not weight bearing and not getting up and moving around. It gets worse with bone reabsorption. We don't have to go through the whole science behind this, but when bone reabsorbs or is resorbed by the body, there's excess calcium that gets that's left over. Where does the calcium go? It goes a couple places. One in your bloodstream, and then number two in your kidneys. Want to know why we start to see more what we call renal calculi or kidney stones? It's because of this. Want to know why you're at more risk for clots? Is because now you have more calcium in your bloodstream, and so the bone reabsorption is a big deal. Age-related muscle loss is called sarcopenia. A faster version of this, which is not really related to it, but it happens in older patients more, is that you can lose anywhere between 2 to 5% of your muscle mass per day. I'll tell you, 5% seems to be more on the ICU side. I've seen the rates as low as like 1 to 3. That's probably like more your med surge, but as much as 5% if you're on the ICU and you're really immobile. And so that's one of the more obvious ones. You're exposed for more chances for urinary tract infections, postural hypotension issues where you feel dizzy going from lying down to sitting or sitting to standing. So all of these things happen. And as they happen, they make the other things happen even faster. And so it's just this whole like maelstrom or there's like this doom loop that happens. And so
we've talked about how when those things happen, we treat them separately instead of looking at maybe one cause that we could actually treat and see if it helps.
No. We're going to bring a specialist for all those things that are happening because we haven't picked out the fact that there's actually a root cause and it is immobility.
And let's don't talk about charting with specialists.
Yeah. So we're going to, what I thought we would do is I had a faulty, and I love being corrected. Especially if I correct myself.
Okay.
It's not something to be corrected by other people. But when I correct myself, but I had a faulty understanding of how the body worked. I used to teach that your physical, rather your internal health got manifested externally in your physical function and your physical health. So in other words, if you're healthy inside, you're going to look and you're going to move like you're healthy on the outside, right? We hear nutritionists talk about this a lot, like fix the inside and then the outside will kind of naturally come along. I think that's true in a younger body in large degree. Where it doesn't go far enough though, is the reverse also happens. And so it's not just that the internal part of your body influences or exerts control or gets manifest on the exterior. Your exterior, how you move, your physical strength also influences the interior. So the stronger your muscles are, the more active you are, the better off your heart is, your lungs are, and all that kind of stuff. And it becomes even more of a bigger impact when we're talking about an older patient, particularly in a hospital. And so, for, a couple hundred years or so, the standard operating procedure for helping someone get past an infection was bed rest.
That's
Why?
right.
Because our understanding was your body has limited resources. So therefore, I don't want to spend resources on you getting up and moving. I'd rather you spend those resources on actually healing past the infection. And what we realized when we actually not magically, they started doing it because of World War II veterans coming back. What they found though is that people who actually got up and moved faster or moved more actually recovered faster.
Earlier.
Because your physical movement actually helps to amplify your body's immune system. And I think that that's a lot of times missed. And so in terms of like preventative stuff, I think it's important that we pay attention to, yes, internal affects your physical abilities, but your physical mobilities most assuredly will affect all of your other organs and systems that you are relying on for health, for quality of life, for all those kind of things. And so one of the lessons that I learned from some of these doctors that I've communicated with, and even like the AMP program, was that a lot of times we have hospital committees on everything. right? Infections, falls, whatever it is. There's a committee on, because, Medicare or the powers that be say, hey, this is a big concern of ours. We're seeing X, Y, and Z happening in hospitals. And so we want you to make sure this happens in fewer numbers moving forward than they have been before.
Right.
Fine. And so the hospitals will set aside and they're like, hey, we need nurses and therapists and doctors on this committee. And we need another group of committees for these. And they come up with all these policies and procedures on how do we help curb this? And I say that to say, word of caution, sometimes we're not paying attention to the downstream effects of some of our policies. And in this regard, what I'm talking about is the committees around fall prevention. And we talked last time about falls in a hospital are a really big deal. They are costly in terms of dollars, and they are costly in terms of time and energy and potential red flag issues for the hospital itself. And so one of the things I learned from Johns Hopkins was that they've actually done studies on the fall risk bands that you get. And what they found, I want to make sure I quote this the correct way. They said too heavily a focus on falls leads to 3 to 4 times less likely to walk. So because they're screening everybody as high fall risk, even those that are only like a minimal fall risk that really could be getting up and moving around, they're not allowed out of bed without a caregiver to assist them. And so we're just natural consequence of if we tag everybody as a fall risk because we're so terrified of falls.
Now they really are.
We're going to make that happen. If you were at a fall risk before, we're definitely going to make that happen now. By the way, we're also going to kill your kidneys and give you some delirium and that kind of stuff.
Sure, why not?
But it was they're good faith efforts to try to figure out, okay, falls are clearly an issue. How do we help resolve those in hospitals? But if we take that too far, then it ends up causing these other issues.
Yeah. And it's hard. That education, when you roll out things like that, it's so hard because one, you've got multiple shifts with nurses coming in different all week, or you've got PRN or as needed nursing staff, and you can only absorb in your sponge, right, as much as you've experienced. And so when you go through these educational modules, because it's usually online, to learn all of these things, you're also charting and answering the call light and answering your phone and expected to pay attention to what's going on the screen too.
Especially if you're at 2x speed like I do.
Yeah, 2x, right. I wish I had known that one a long time ago. But then how do you interpret that? You're going to do your own bias on if it's not intuitive enough.
Well, if you think about it, if the hospital's one of their main priorities is we have to reduce falls and we're going to monitor these and we're going to track them, then you don't want to be the nurse or the therapist that has a fall with one of your patients. Like I kind of get that. It's like, if this is where I'm supposed to be focusing on, then I'm going to bias more towards that and less to immobility. And what they did, there's been a number of studies that Johns Hopkins has done when you actually start to utilize a less sensitive, I don't want to say less sensitive, when you're less scrutinizing on the fall risk and you are allowing people who are just mild fall risk people, which is kind of everybody to a certain degree. If they're slightly weak, they're considered fall risk, which isn't necessarily the case. If you are less sensitive on that piece of it, they actually find there's hundreds of thousands of dollars of savings just by getting them up and moving them, or not tagging them as a fall risk when they're really not.
Well, and we've talked about that fall risk is a deterrent for people who are not the nurse to help them get up out of the bed because they don't know where that patient is. And all they know is, that says high fall risk. Oh, wait a second. Let me get your nurse, which then is more work.
That's a great point. Yeah, because you could have just used the aid, right? With the aid looking at the band going, I don't know about this one.
The aid, no. I'm glad they have an aid.
But you know what I'm saying? Like if I see someone of the higher fall risk, I'm thinking, ooh, this is probably not a one-man transfer.
Yes.
Right? This is probably two because they're high fall risk.
And if you fall, oh my gosh, it'll be on me. And I want to do everything right. Plus safety of the patient first.
Yeah.
And that's telling me you are not safe by getting up.
You got it. Yeah. So it's fascinating. So back to your point about, you mentioned, there's PRN nurses and contract nurses and all this stuff in hospitals. And so one of the things that some of the hospitals, I actually really like this idea because there should be mobility goals, right? So there's a mobility goal every day for your patients that are in a hospital. Then it doesn't matter who shows up in there, right? Because usually you have that big whiteboard that says, Nurse Keeley, here's your, the doctor on call for the day or on rounds for the day. Here's who your therapist is. If there is ask for a therapist. But if there's no if there's a therapist, there'll be a therapist on there, and any kind of other important information.
Right.
That might be the nurse on charge
when your
duty.
meds are. I mean, you want me to go through it?
Yeah,
it's
but
a lot.
Anyway, every place has a board.
Yeah.
Today's date, in case you forgot what today's date was because you're cooped up in a hospital, right? But on those boards, they're actually putting a mobility goal, and they start really simply. It obviously depends on where you're starting, but some of them could be just up for meals 3 times a day.
Yeah.
Some of them could be, hey, we're going to walk 10 feet today, and then tomorrow it's going to be 50 feet, or we're going to get to the bathroom today. And so they're actually putting
to the side of the bed.
Yes, can we at least do that? Yeah. But it starts like if you're someone who's really immobile and really weak, you're probably just starting with, can we get them up for meals? Great. And then tomorrow is going to be adding additional and here's the thing with these mobility goals. And I was just teaching this class, actually, the hospital-acquired frailty thing in a hospital just before we did the show today. And I was trying to tell them, like, there is a time for like rehab. When we think of rehab, we think of like trying to recover from some sort of incident, injury, whatever, right? We're rehabbing. We're trying to get back to our normal baseline. In this context, though, it's not about rehabbing. It's about prevention. If you can get somebody moving, we avoid this precipitous decline. And so that's why they call it Every Step Matters. It's like it's their slogan. But some of the hospitals have adopted this program called Every Step Matters, and they are literally setting up a mobility daily mobility goal that their staff has to attain to, which is great.
I love that because it fights that culture or that acceptance of we are not a rehab. So we diagnose, we treat, we stabilize.
If you're not a rehab, you're supposed to be preventing immobility.
Yeah, let's just diagnose the functional mobility problem and tell you where you have to go to get treatment.
Right.
But instead, it's that proactive approach, which I think is why a lot of nurses leave the hospital because we're constantly responding to problems. Where is it where we can be preventive and get a patient up to the chair? Like that feels easy sometimes. You know,
you may need to call for some help if they're a heavy lift or whatever. Yeah. Well, they have there's a hospital system out of Louisiana, and they have a green flag and a red flag system. This one's, you've heard about this before. Yeah. And so I can foresee some problems with this because there's probably some HIPAA stuff in here, but whatever. Their goal in mind was, so I won't mention who they are, but their goal in mind was, how do I further incentivize the clinical team and the patient and family to go along with this? Hey, mobility and prevention matter. Like, we got to prevent all these bad things that happen from being immobile. And so they have a green flag and red flag system. And so it's kind of like, on the hospital doors, there's usually some sort of a flipper. I don't know what you call those things, but they put a flag on there. Yeah. And if you met your mobility goal for the day, you got a green flag. And if you haven't, you got a red flag. Right. So
we're going to shame you now.
You are in stage for everybody else. Shame on you. You did not get up and meet your mobility goal today.
Your whole care team.
Yeah. But what's funny is it creates a little bit of friendly competition with the other patients on the floor, and even within the clinical teams, which I kind of like. I can see an issue with, probably should not broadcast, but and
that patient doesn't get forgotten.
Right.
We talk.
Yeah. 4:00 in the afternoon. You're still hitting red today. We got to move that to green. Yeah. I can see how that could work. And they're seeing some success with it. So I'm sure they can sign a thing. The patients can sign a thing and say, hey, we have a competition on this floor. Yeah. Are you okay with that? Yeah. You had mentioned something on the ICU, which is fascinating. So
yes.
We'll do a proper segue to ICU.
Okay.
So if this is what we talk about right now, is like normal med surge floors, right?
Yeah.
Somebody who's sick, obviously not well enough to go home quite yet, and potentially is declining in a hospital environment because we're not getting up and moving them. If you take that to the furthest extreme, that would be like ICU patients. And you got connected with somebody who actually teaches this program around the country on the importance of mobility, even for ICU patients, which when I learned the stats on this, I was blown away. I'm like, okay, this is a perfect example. If it works in this context, it's going to work on the med surge. Yeah.
Right. And when you've been presenting this, we have these naysayers that come out, and I get it. When you've been doing the same way, you think that it won't work, right? Yep. And well, you and I are out to change healthcare, and so this is part of it. Yep. But I love that I'm following. So Dr. Dayton, I think her name is Kaylee, but I don't want to say it wrong.
It's Kali.
Yes. Yeah. But she's a nurse practitioner, and she is just paving the way for awake and walking ICUs. So these are ventilated patients, so they're on life support. And the trend in healthcare is that, oh my gosh, the ventilator hurts to breathe for you. It's a traumatic experience for us to intubate you. So we're going to sedate you so that you can sleep through this experience. And what Kaylee's program is, it was started by Polly Bailey. I was reading about that the other day. So 30 years ago, she started this. Can you imagine?
This is not new information.
No, but how frontier that was. Is that the right word for it? Yeah. Because so 30 years ago, she actually had a patient that she went and visited at home, a survivor. And she saw the devastation that the sedation and delirium, months later, physically, cognitively, emotionally had on this patient. And she said, I know I saved her life, but did I? Interesting. Mm-hmm. And so so then she went back and she had apparently amazing doctors that listened to her, let her try out things like getting vented patients up and out of bed. And that's how this whole movement kind of started. Okay. And so Dr. Dayton is the Dayton ICU Nursing Consulting, and she does a podcast too. So just a shout out for Walking Home from ICU if you want to know more information. But what she talks a lot about is she talks a lot about patients and their experience that they will tell you, especially, if you've been intubated before, you're at a high risk of being intubated again when you come into the hospital, depending on what your health problems are. And she writes about how patients will choose this to be awake and walking. So let's get to the meat of things that has to do with what we're talking about. And I think if I put on my financial hat as a case manager, because that's where you kind of have to speak the language of the hospital, is how will this benefit the hospital in the long run? Yeah. So in one of the medical trauma ICUs that she trained, they reported in 3 months $500,000 in savings.
Jeez Louise.
Yeah. $500,000.
What did they add in terms of staffing? I'm sure there's therapy visits and that kind of stuff. So what was the cost side to get that return?
So good question. I like that. So with the therapy alone, they went from 2 to 4 therapists. So they doubled, right? Yep. So a cost.
$200,000.
But they saved $8,000 a patient with that. That's huge. So we're talking about when you come into the hospital, the ICU is the most expensive stay. Yep. An average stay that's expected is about 12 days, depending on your diagnosis if you're ventilated. Okay. So when they're doing this program, she reports that by increasing those physical therapists and occupational therapists, they're decreasing the length of stay by 3 days in the ICU.
25% more. Yeah.
That's huge savings.
Yeah, I think she was when I saw, she quoted a statistic, said something about every 10 minutes of early mobility decreases it by 1.2 days or something.
Yeah, something like
10 minutes of extra.
10 minutes.
Mobility.
Yes. In the ICU patient. So when I transfer that to, hey, you naysayers, I know you don't think that this can happen. This is ideal medicine that we're talking about. Right. Well, she's the proof, right? And so how do we transfer that program into our medical surgical units or our step down units where they're not intubated, but they're still being kept in the bed because of certain issues like heart rate, blood pressure, delirium, where those problems sometimes can be fixed.
I know.
It's a catch-22.
I think this goes back to the way that I used to see the body too. You don't understand that muscle is actually the safeguard to health.
Right.
And because of that, you're trying to focus on all the internal organs that may or may not be failing, and they probably, if they're being more immobilized, they're going to fail faster. But you're so focused on those internal organs, which are important, right? Because obviously the muscles don't work if the internal organs don't work. But we're so focused on that piece that we neglect the fact that, oh my gosh, actually through muscle work, you actually salvage those.
Yeah.
And I think that's a big change in our perspective. I think once people get there in mass, where they start to realize, holy smokes, like actually the mere fact of contracting and relaxing muscles actually helps to further amplify all the good care we're doing for the internal organs. I think once they get to that point, they'll start figuring out, like Kaylee had.
I know. Let's call her Dr. Dayton. Yeah. Dr. Dayton. It's the safe one.
Like they have, there are logical questions of, okay, how do we do this safely? If we got somebody who's intubated and there's all these tubes coming out of them in an ICU, what does that look like? What's the program look like to do that safely?
Right.
But I use her because I know she's done a ton of research on this. If we can do it in that setting, we can definitely do it on the med surg floors and at the skilled nursing facility level. The rehab hospital level, here locally, I'm not really too worried about them. They're pretty active.
I mean, that's the whole goal of care.
Yeah. Well, it's supposed to be that way for skilled nursing facilities, but they've kind of cut down some of their therapy in most facilities. And so, at least if we can get them to where they're getting up and moving on a regular basis.
And when you say they, you mean their reimbursement, not the SNF.
I mean, the reimbursement drives behavior and there's less therapy being delivered.
I just want to make sure
SNFs.
that it's not them, it is those who pay them.
Yeah, they did drop their thing. Yeah. So anyway, but the other thing, I think I'm always going to be on this kick because I hear this all the time from I work with a lot of senior living communities. And so I get a lot of phone calls from family members who are like, hey, my mom lives at XYZ ALF or an independent living facility and she just had a fall. She's going to the hospital. We're going to use you guys when we come home. And I'm like, great. Here's a couple things to pay attention to while they're at the hospital. And they'll call me like a day or two later and go, Brian, I'm just not sure. It looks like she's going to have to go to memory care. And I'm like, why? And she says, well, because, she's got a new diagnosis of dementia. And I said, did she have a diagnosis of dementia before the hospital? Well, no, but she's gotten really bad. And so I'm like, nope, it's called hospital-acquired delirium.
Right.
And so this one, if we can just get them up and move, it solves a lot of those issues with that too. It's some of it's that I know you've worked with a doctor here in Plano about the sedation part of it. That's part of it too. Like being careful, the medications we're putting them on is a huge, benzodiazepines, I think are like a big deal for delirium. So watching medications that we have them on, but also just getting them up and moving them, getting them up in a chair regularly for meals, like is a good start. They say over 50% of hospitalized patients over the age of 65 experience delirium. Half.
I know. It is. It's so hard to think about that.
Yeah. And just the mere fact that you get diagnosed with a new dementia or delirium diagnosis adds another 5 to 10 days to your stay.
Well, and if you've never experienced a loved one going through delirium, it is so hard to watch because they're, scared, they're hallucinating, they aren't safe because they're impulsive to get out of the bed. And so then medicines get put on to try to keep them in the bed that only exacerbates it and increases their risk of mortality because they're just not processing it. And they're going to stop breathing now. And now we're going to send them to ICU to get intubated. And we bought them that ticket because we weren't getting them up because we were scared.
So here's the shocking stat. So half of patients over the age of 65 will experience delirium going through a hospital system. Of those 50%, 40% of those will have long-term side effects on their cognition. 40%. So half of them will never get back to their normal.
Never come back. Yeah.
And it was so preventable. It drives me crazy.
Yeah.
So it increases cost to obviously the hospital because they're keeping them there for longer too. So the immobility piece of it, again, I can't stress it enough, is not just for the muscle strength and my ability to get to the bathroom. It affects so many other internal organs, and the most important is your brain. And that's probably where that other doctor was going, where she's like, I follow these patients home. Did I really help them? Because their quality of life is so substandard from what they used to before because we did this and we left them in a bed for too long.
So I actually was reading too, Dr. Dayton has a lot of different people that she works with and connects with. And there's something that I didn't know about. Again, I haven't been in critical care for a long time. So it was neat to read about verticalization treatment. How do I say that? You got me.
Tipping them up on a bed.
Yes.
So vertical.
Yes.
Okay,
Have you heard about this?
I've seen it. Yeah.
Yeah. So it's no flexion in the hips. So if a patient isn't able to sit up or get up, this puts them into a position where how you talk about just sitting in the bed isn't enough because they're not using their diaphragm muscles.
The respiratory muscles.
Pulling them back. Well, this puts pressure on their legs depending on how much they can do. So it's mobilization.
It's at least weight bearing through joints. So we're reducing some of that. We call it Wolff's Law, but it's the bone resorption that causes increased risk for calcium in the blood supply, which causes, more clotting, or I shouldn't say causes more clotting, causes more issues with potential clotting and, kidney stones.
Yeah.
So we're at least getting some weight bearing through them, which is great.
But the emotional
postural hypertension issues we solve with that.
Because of the baroreceptors, learned about that.
Yep.
But
you're going to be a PT before long.
I know. I love it. I'm learning so much. But I also, one thing that was really striking to me was that the emotional part of this ICU patient that can't get out of bed, that would be flat otherwise, just by setting up, gives them, what did he call it? It engages something in them to think that they can get better because they are up.
It's the perspective.
Yeah.
Vertical versus horizontal.
Yeah,
I can see that.
I'm sick laying down.
It's interesting. This totally off topic, but I bet that's why they do this too. It's newer technology. It's not like brand new, but they've had it around for a few years. But there's a thing called eye level, which is wheelchairs that have an elevator to them. And the point of it is to get the chair so that you're now eye level with other people around you. And there's a huge psychological component to that. If I'm always having to look up at you, or if I'm laying in a bed looking up at you, what does that tell your brain?
Right.
Like I'm sick and I'm getting sicker, right? And
you're looking down
you
on
feel more dependent that way. So I can totally see how that changes something in the psyche or in the psychology.
I thought it was just really powerful for sure.
It's amazing.
Yeah.
So there's some simple things that we can do. There's a lot of studies out there of people working on some fascinating ideas on improving the hospital mobility. I would say the one thing out of all that, one additional thing I should say is there seemed to be a consensus. If you look across these mobility programs that I'm seeing and I'm hearing about across these hospitals, nationally and internationally, is they recommend mobility goals of 3 times a day. Short story or short explanation. There's a difference between what they call massed practice and distributed practice. So mass practice would be like me going to the gym, right? I'm going to carve out 45 minutes to an hour and I'm going to bang out all these repetitions and sets in one solid period of time. That's mass practice. There's a benefit to that in a rehab or a post-rehab progression, right? Remember, rehab is getting back from the decline. If we're talking about, though, a preventative rehab, I don't even know that I want to use the word rehab because it implies something different, but we're talking about prevention, is 3 times a day of getting somebody up and moving around. Because all we're trying to do is teach the brain, I'm giving you an incentive to prevent the decline. If I get you up, I'm going to move you, don't decline, right? There was a guy, I'm not drawing a blank on his name. I just saw him on a podcast recently. I think he's a bodybuilder. And they found that you don't actually, for bodybuilders, they don't even actually see, even though you'll feel within a week of not exercising, you don't see the muscle loss effects for, I think it's like 2 to 4 weeks. So it takes that much longer. But if you just do 1 time a week, it maintains it. Like it doesn't take much. Now, obviously with an older body, the rules are different, right? 3 times a day, but 3 times a day seems to be enough. That seems to be like the consensus. I hate the word consensus, but it seems to be where everyone's landing on is 3 times a day is the ideal position of, if we get somebody up and move them 3 times a day, we can prevent a lot of these challenges from immobility.
So the fall prevention class that we do, they call it snacking on exercises.
Yes.
I like that.
It's the same concept, right? It's distributed practice throughout the day that's not so taxing, but it seems to be enough for this aspect of the patient journey in a hospital. That seems to be enough to positively impact all these other challenges we get.
It takes it down easier. We've talked about that, where it's not such a big thing, right? Just to make it even more a positive spin, that the program that we do also talks about how in older people, you actually start seeing changes a lot faster because it doesn't take much, right? When you're that weak or deconditioned, that you start seeing.
Any untrained person sees progress faster. That's right.
Yeah. So that was inspiring to me, because when I watch you work with patients who have come out of the rehab and are safe discharged to home, but that's when the real work starts. You know,
right.
It gave me a little bit of inspiration and hope to be like, you know, you can do this. Right.
I wouldn't say the real work starts at home. I'd say
it feels like it.
I know they do a great job in rehab
there's
hospitals.
No hospital bed. There's no one to take care of them. That's what I mean.
The work kind of changes in terms of environmental, but totally.
They've been through a lot before then.
But little bits at a time can be shown to be very, very effective in helping to curb some of that loss from immobility. So there's our takeaways. Get them up and move. There's lots of programs around the country that are already proven this, including in ICUs.
Be the nurse who doesn't walk away when your patient says, I don't want to get up out of bed.
And I can't express enough. If you have a loved one going into a hospital, please take a picture and post it on their whiteboard. This is what my mom looked like 2 weeks ago.
Right.
It will change everything, because everyone who's walking in there sees your mom already on the decline. And this is her norm. That's not, we need to change that perspective. So take a picture that was 2 weeks ago that shows her lively.
Show it to everyone.
Yes. And go, that's mom or that's dad. And so we don't accept that this is what has happened to her in the last 3 or 4 days. This is because we're not getting up or moving her.
Right.
And so that could be a huge thing too. So hopefully that's helpful. That's helpful.
Thank you, Brian. I love this topic.
Yeah, it's fun. All right. Thanks, Lesley.